This is also regarding a common illness with, actually the topic itself will say it's about filariasis. So it's so common and we are in an endemic area. And funnily, we got this patient who is from a more severe endemic place. And we'll just, Ashwati will be revealing it further.
Good evening all. I am Dr Aswathy, DNB resident at Rajagiri Hospital. Here I am presenting a short case of a common disease that presented with uncommon symptoms. So coming to details, a 55-year-old gentleman hailing from Bihar presented with complaints of abdominal distension and dull aching abdominal pain since 4 months, unsatisfactory bowel evacuation, loss of appetite and weight loss. So he was apparently normal 4 months back when he developed mild abdominal discomfort with unsatisfactory bowel evacuation. It was not associated with abdominal pain. Initially, it was not associated with abdominal pain, and no history of vomiting, heartburn, or fever. He also complains of reduced appetite. Since 2 months, he feels mild abdominal distension and mild diffuse abdominal pain also, and history of weight loss of 6 to 7 kg in last 4 months. He is a known case of diabetes mellitus on regular medication since 6 months, no history of other non-comorbidities. And he also complains of reduced appetite, constipation was there, no history of alcohol consumption or smoking. So on examination, he was conscious, oriented, vitals was within normal limits, chest, cardiovascular system, CNS examinations also were within normal limits. Examination of abdomen, abdomen was soft and mild diffuse tenderness was there and mild distension also. External genitalia examination, on inspection it was normal. On palpation, small cord-like structures was there. And on investigation, all preliminary investigations were within normal limits except ESR, which was elevated, mildly elevated, which was 27 millimeter per hour. And eosinophil count was mildly elevated. 7% of eosinophils was there. And absolute eosinophil count was 500 cells per millimeter cube. And peripheral smear showed nomocytic nomochromic blood picture. Due to persistence of his abdominal symptoms, we have done upper GI endoscopy, which was within normal limits. And USG abdomen was done with CT correlation, which showed lymphangiectasia involving the cisterna chyli, bilateral lumbar lymphatic trunks, and major scrotal lymphatics with associated paralleling lymphadenopathy. As lymphatic dilatation is extending to scrotum, we have done USG scrotum, which showed moving tubular structures suggesting active filarial parasites. That is, filarial dance sign was there. It was suggestive of gonadal as well as retroperitoneal lymphatic filariasis. This was the USG scrotum and spermatocote finding. There were multiple actively mobile tubular structures, and this is the filarial dance sign, diagnostic of lymphatic filariasis. And Doppler shows irregular blood flow. And peripheral smear was done for microfilaria. As microfilaria shows nocturnal periodicity, it was taken at 12 a.m. At night, but it was negative for microfilaria. As patient is from a place endemic to filariasis, and USG showed diagnostic sign of lymphatic filariasis, that is filarial dance sign, we have started with the diethyl carbamazine therapy, 6 mg per kilogram OD dose. And within 2 days of therapy, he started to show clinical improvement. And he was reviewed after 7 days and he showed significant clinical improvement. All his symptoms were subsided. And we have completed a total of 14 days of diethyl carbamazine therapy. So here a common disease in a tropical area presented with uncommon symptoms. A little description regarding filariasis. As we know, filarial worms are nematodes that dwell in the subcutaneous tissues and lymphatics. And lymphatic filariasis is caused by Wuchereria bancrofti, Bruchia malai, and Bruchia tumori. And these infections are transmitted by mosquito vectors, and humans are definitive hosts. So this is the life cycle. Microfilaria is the infective form. And approximately 2/3 of individuals infected with lymphatic filariasis is in Asia. More than 90% of cases of lymphatic filariasis are due to Wuchereria bancrofti. And the most common presentation of lymphatic filariasis in a patient from an endemic area is asymptomatic microfilariemia. Acute cases present with acute adenolymphangiosis and fever, and in chronic cases they present with lymphedema or hydrocele. So active lymphatic filariasis is defined as defined by microfilaria, antigen positivity or filarial worms in ultrasound. So diagnosis is by either antigen testing, especially used for Wuchereria bancrofti identification. Circulating filarial antigens are identified either by ELISA or immunochromatographic technique. Then peripheral blood smear for microfilaria, but it's having very low sensitivity. Then antibody detection, PCR, USG, diagnostic sign for filaria, as we know, filarial dance sign. Then lymphoscintigraphy can be done. So treatment, according to central government protocol, diethyl carbamazine 6 mg per kilogram daily for 14 to 21 days. Diethyl carbamazine is both microfilaricidal as well as macrofilaricidal. So it is also recommended for microfilaria negative carriers of adult worm. Then alternatively, we can use capsule doxycycline 200 mg per day for 4 to 6 weeks. So, thank you.
So in this case, actually there is no need to teach about microfilaria or filariasis in this audience. But even from my days, I think from my experience also, I have never seen after the SPM classes and the slides, I have never seen a peripheral smear with microfilaria, even though we have done it many times. And interestingly, I was just talking to them, and my experience or my encounter with microfilaria is when I think in the 70s, when we were just small kids, the health service people used to come knock at our doors at 10 a.m., 10 p.m. night or 11 p.m. and we would try to run for cover in the night. So they were very active searching for this microfilaria and nighttime smears and all. But it's a very clumsy test, and even though we had looked for it, we have never come across any microfilaria as such. So this microfilarial dance or filarial dance is very interesting. So that made it very interesting. And though the patient did not present with filariasis or elephantiasis or anything, because we could pick up from the dyspepsia signs and all, he was treated well. So he was well treated, and he was symptomatically much better. And only when this patient came, and when we read about it, we found that Bihar is more endemic place than us in case of filariasis and all. So I think.
What about the follow-up of this case?
So I think.
Symptomatically improved after 7 days of DEC with no further symptoms, and he went back to Bihar, so that repeat UST we haven't done.
That's what I was just mentioning, that if we could get a repeat ultrasound, we could have saw whether the dance was over. But that we didn't see. So hopefully your dance is still continuing.
But I think at least another course of diethyl carbamazine should be given for this patient after 6 months and after 1 year.
I think we should be on the lookout. So, or all the seniors would vouch for it, that they have been, even when I started.
Raju sir may have much experience with treating this.
We've seen patients. Yeah,
So
we've seen all the senior doctors prescribing DEC for many patients, like patients who come to us with fever, unknown fevers and all. But that is not a common practice nowadays, but all the physicians all used to give that. Maybe because of that, we are not seeing so many filariasis now.
Raju sir.
Yeah, did the patient have any fever?
No history of fevers.
So he came with some dyspeptic symptoms, wild abdominal heaviness, bloating and all those things. So actually the endoscopy and all were initially done by the gastroenterologist. They went to him. And in both the cases, I can assure you that there was a team of all the specialties. Although we were taking the credit as physicians, all the specialties were involved in this. So that's also one thing that we learned. So thank you for the patient listening, and thank you API for giving us the opportunity, for organizers again. Thank you.